Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Hello, everyone. We have Dr. Faisal Haroon today here with us, who is the Assistant Professor of Medicine in the Division of Hematology and Oncology at George Washington School of Medicine. He completed his residency in internal medicine as well as his fellowship in hematology and oncology at the George Washington University, where he also served as the chief resident. He is now the assistant professor in the same department and has a special interest in lung cancer. He's very invested in the novel therapeutics such as the immunotherapy and targeted treatments, which are aimed at improving the outcomes for our patients with lung cancer. Dr. Haroon has also recently stepped up as the Fellowship Program Director of the Hematology Oncology Program at George Washington University. Welcome, Dr. Haroon, and thank you for joining us tonight to talk about lung cancer.
Dr. Thibault, thank you for the very kind words and the introduction. I'm looking forward to chatting with you today about patients with lung cancer and about lung cancer in general.
Thank you. Yes, the hope is that this talk creates awareness about the lung cancer and also talks about some of the treatment options which might help our patients understand and learn more about the disease. As we know that worldwide lung cancer is one of the very common cancers, and it is known to cause lots of deaths annually throughout the world as well as the United States. Although recently with the new advances, in 2020, estimates of the new cancers indicate that the lung cancer is doing much better than how it was doing in about 3 decades ago. What do you think about the prevalence of the disease and the patients that get referred to you?
Yeah, it's very important. Lung cancer is one of the most common cancers in both men and women, and it's one of the deadliest cancers in both men and women. And in the United States of America, more than 100,000 patients every year die from lung cancer. So definitely, it is a very devastating disease. It's a disease that affects patients across the nation of both gender, women and men. It is estimated that although lung cancer is one of the most common cancers, its rate is going down a little bit, and that's because of all the changes with smoking cessation and patients cutting down on smoking. So that's very important. And because improvement in treatment in lung cancer has also decreased the deaths in patients with lung cancer. So there's a lot that still needs to be done, but lung cancer continues to be the number one killer with cancers in patients, both men and women in America.
All right. Dr. Haroon, so everybody knows that the primary risk factor for development of lung cancer is cigarette smoking. And that's why, all these things about stopping smoking and what to do to, get rid of that evil. But are there other risk factors also that you see have caused lung cancer in the patients that you treat?
So this is how I want to the answer to this question. If someone asks you what is the cause of lung cancer, it would be smoking, number 1, number 2, number 3, all the way up to number 10. And then there's reasons beyond that. But the most common cause of cancer in the lungs is smoking. And if a patient smokes a pack of cigarettes for 40 years, that person is 20 times more likely to get lung cancer than a non-smoker. So definitely smoking is the primary reason of lung cancer. That said, I'm specifically talking about smoking cigarettes and cigars and consuming tobacco products. But the other question that is on everyone's mind today is vaping a cause of lung cancer? I think that the jury is still out there. The thought is that it probably does increase the risk of lung cancer. We don't know if it does increase it at the same extent as smoking cigarettes, but it's something to keep in mind. But the question you asked about other causes of lung cancer other than smoking? And the answer is yes. We do see lung cancer in non-smokers, especially that today the majority of Americans don't smoke. We still see lung cancers in those patients. I would say 10 to 20% of all patients we see with lung cancer are non-smokers. And if you're a patient that comes to me and asks me, doctor, why do I have lung cancer? I've never smoked in my life. I would have to say, it's hard to say, but there are a lot of causes. One is maybe secondhand smoking is something that we need to think about. And then other exposures, such as asbestos, is one of the causes of lung cancer. And then the list goes on and on. It could be, exposure to radiation, and then other environmental factors and toxins. And other causes that we can think about, other lung diseases such as, fibrosis of the lung. Alcohol has been associated, but it's very hard to say if there's a direct effect to causing lung cancer. And we do know that lung cancer incidence is higher, it's somewhat higher in patients who have HIV. So there's a bit of other risk factors. When we talk about genetics of lung cancer, it seems to be that there is not a strong genetic link in lung cancer, in the sense that, yes, lung cancer sometimes happens in families, but it just tends to be that there's a lot of smoking in these families. Again, there could be a small genetic risk that leads to lung cancer in families, but I don't think that is a major risk factor. But that's something to think about. But again, the majority of lung cancers are caused by smoking, and a small percentage caused by other exposures to toxins such as asbestos, radon that is very present in our environment, and it's very hard to avoid radon. And it can be exposure to radon, which is a gas that we don't smell and we don't feel. It could be exposure to radon when folks are younger or in their middle age, and that takes many years for lung cancer to develop. So I think that's what I wanted to say about lung cancer. And then, the other question is, can we do anything, in our diet, in our vitamins to decrease the chance or the odds of getting lung cancer? Again, it's a very, very tough question, and I think that it's very hard to say. And some studies have been done to see if some vitamins, beta carotene, B complex vitamin decrease the risk of lung cancer. And the answer is no. That association was not found. And in a few studies, there's even a thought an increased risk in some patients who are getting some vitamins. So I wouldn't say there's anything that can be done differently about the diet. Again, smoking cessation is number one, and smoking cessation and not starting smoking even in younger years. So smoking and quitting smoking before the age of 30 can decrease the risk of lung cancer specifically.
That's good to know. Thank you for the detailed answer, Dr. Haroon here. So talking about the lung screening, the U.S. Preventative Services Task Force has recommended the CT scan. What do you think about that? Do you practice that? Is that what you recommend? Is known to cause prevention and decrease mortality?
Yeah, and patients who have a history of smoking, and typically what we say is if a patient has smoked 30 packs, and has quit less than 15 years ago and is above the age of 55, we do recommend a low-dose CT scan to look for early signs of lung cancer so we can treat it early or prevent the development of high-grade or higher stages of lung cancer. And 2 studies were done, but one major study showed that using screening methods, so basically the low-dose CT scan, can decrease the chance of dying from lung cancer by 20%. So it's not a major decrease, but it's a significant decrease of death from lung cancer by using screening methods. Again, let me repeat those. If you're above the age of 55 and you've smoked for more than 30 years, a pack a day, and has quit less than 15 years ago, please go to your doctor, your primary care doctor, your pulmonologist, or your oncologist if you have one, and ask your doctor for a screening test, which is a low-dose CT. So it's good because it doesn't have a high dose of radiation. We here at George Washington University have a screening program where patients can be enrolled to get CT scans by their primary care doctor or their pulmonologist, and the scans are usually done yearly.
Okay, so yearly for how long, Dr. Harun? Do you do them for the rest of their lives? So let's say somebody is 70 and has now quit smoking, but still falls in that category where they've had the 30-pack years of smoking history and quit like 5 years ago. So they will do a CT scan for the rest of their life. Is there at some point where you say that they're low risk enough and do not need the screening anymore?
I think that once someone gets above the age of 75 or 77, then we might opt against screening at that point. Another thing is if a patient has stopped smoking more than 15 years ago, we also don't screen at that point because the risk of lung cancer starts becoming much lower. The initial study showed that screening for 5 years is the most beneficial. I still do screening beyond the 5 years, but it's very crucial and important to get screening for the first 5 years when you present to your doctor. So that would be my answer, but I do screening all the way up to 15 years from quitting smoking. I think that's the key.
That's good to know. Thank you, Dr. Harun. So switching gears to talk about the different types of lung cancers, the different histologies or the different pathologies. We all know there are the two main kinds, a small cell, which is known to be much more aggressive, and then the other kind, which is the non-small cell, which tends to be a little less aggressive than the other kind. Why do you think it is so important to know about the distinction from the get-go and how it affects the treatment options and the prognosis for our patients?
Yeah, I think that that's a very important question, and I think a lot of patients don't think about this, but definitely from an oncology standpoint, us cancer doctors think about that. Think about the pathology of the cancer whenever we see a new patient or new diagnosis of lung cancer, and the reason is that although we call them all lung cancers, they're quite different. Yes, those cancers started in the lungs, but they're very different types of lung cancer. The most aggressive type is called small cell lung cancer, and that has to be treated very quickly to prevent its growth and its spread. It can respond to treatment very well, but it is aggressive. It is aggressive form of lung cancer, and we call that the small cell lung cancer. It almost always happens in smokers, and it's depending on the rate of smoking in your state or area. It can be as low as 10% and as high as 30 or 35% in some areas. So definitely caused by smoking. It is more aggressive and can spread to a lot of areas in the body, and it's typically treated with chemotherapy plus or minus radiation and rarely treated with surgery. And then we go to the other types of lung cancer. We used to lump them all together in one category and just call it non-small cell. So there's a small cell and then the non-small cell. But the non-small cell lung cancer was found to be many different types of lung cancer. One is called the squamous type lung cancer, and that also mostly happens in smokers. And then there's non-squamous types of non-small cell lung cancer. And again, I apologize to patients. I wish the names were easier. But in truth, the naming matters a lot. So there's a small cell, and then non-small cell. And the non-small cell, we have the non-squamous, and then the squamous. And then in the non-squamous, there's a lot of subtypes too. But the most important and most common one is what we call lung adenocarcinoma. Lung adenocarcinoma happens more likely in smokers, but can happen in non-smokers. And again, for this adenocarcinoma, there's a lot of different subtypes, and I call them genetic footprints, or the genetic makeup or the DNA of those cancers. And it's quite really important to know about this because that affects treatments early and late, and it affects prognosis, so how well you do. And we have a lot of different targeted therapies that have emerged over the last decades, and every year we get a couple new drugs that match the specific subtype of this cancer. So if you know what genetic makeup of this cancer is, you can better understand the treatment modality that works best and prescribe the right medicine for the right patient for the right cancer. So we give medicine that works and not just treat and hope the treatment will work. So in addition to some of the treatments like chemo, radiation, surgery, immunotherapy, there's targeted therapies that have emerged over the last 10 to 15 years. And there's a lot of small subtypes to match it. So one subtype of non-small cell, so basically adenocarcinoma, is what we call EGFR mutated. And we have pills that target that mutation. And that mutation can happen in adenocarcinoma as low as 10% in some populations and as high as 30% in other populations. Typically, we see that in women, non-smokers, more Asian populations, it can be much, much more common than that. And then there's other types, the ALK, there's the ROS1, and then there's other mutations like BRAF, MET, RET, NTRK. I mean, the list goes on, and every year we're gonna add new mutations and new targeted therapy. So by the time you guys listen to this, there might be a new drug, a new mutation on the market. So it's very important to test the biopsy, the tissue, the cancer that is taken out or biopsied, to test it for the genetic mutation, so we can figure out if there's a drug or that can be matched specifically for the specific type of lung cancer. And again, Dr. Thibault, I don't know if there's anything else you want to add here, but this is quite important, and it's very important to look for those mutations. And if not, there's other things that we look at too, but it's not just lung cancer. It's not just non-small cell. There's subtypes what we look at that can help us treat patients. Early stage, late stage, patients that are older or younger can be candidates for these treatments.
This is very important. I agree with you, Dr. Haroon, that knowing the subtype analysis or knowing the specific gene mutation so that the individual therapy can be tailored is very important. And I think I find it very interesting that the specific EGFR type of lung cancer, the adenocarcinoma, which carries that particular mutation, is present more in certain populations such as Asians. So that might be of interest to our patients, as well as in younger and women. So, and again, as you said that, there are all these new drugs coming in. You think these drugs work better than the conventional treatment options which were present before? Can you shed some light on why it is more important to our patients to know if they carry a specific targeted mutation in terms of their future prognosis and the toxicities from the treatment?
Yeah, Dr. Thibault, you just hit the nail on the head here. It is very important to know about those mutations because how well the patient responds to treatment depends on those mutations. So first of all, patients and doctors love options. So the more options you have, the better. So we want to know what are the treatment options. Is it chemo? Is it immunotherapy? Is it radiation? Is it surgery? Is it those to targeted therapy? And then we pick the one that works best and has the best chance of working. And we do know that patients that have an EGFR mutation, starting a pill that targets EGFR has a chance of working to control the disease for a year, 2, 3, or even more than that. Can be above 85-90% in some patients. And those pills in some occasions can be very, very well tolerated, where taking that pill can control the disease and shrink it. And patients, other than taking the pill, will not need chemotherapy, will not need other therapies, and it can be watched every 3 to 6 months to see if there's any chance that this cancer is growing. So yes, specifically for EGFR, it's very important to know, and very important to know early so we can decide how we're going to treat and what is the best first-line treatment for those patients. So I 100% agree with you that those targeted therapies in some cases are very effective, and the most effective, that they should be used first line in patients to control the disease if the disease is not amenable to surgery or radiation.
Got it, Dr. Haroon. Thank you for that. And then, Dr. Haroon, not just these targeted mutations, these are separate from the immunotherapy options. Do you test for who are the candidates for immunotherapy also from the get-go? Is that what you practice with your lung cancer patients? Because as you said that, it is very important to know if they have these mutations and they can be candidates to just get the oral chemotherapy, which is very easy to take, and also during these COVID times doesn't require patients to come into infusion centers and clinics for multiple trips of IV chemotherapy. Where does the role of immunotherapy fit in with these new mutations and these new targeted therapies?
Yeah, I haven't talked too much today about immunotherapy yet, but immunotherapy has changed the way we treat lung cancer significantly. to the point where sometimes it is the only thing we give patients that are presenting with lung cancer stage 4. So what is immunotherapy? Immunotherapy is the drug that is given to the patient intravenously in the vein. It can be given every 2 weeks, every 3 weeks, every 4 weeks, or every 6 weeks, depending on which immunotherapy drug we choose. So there's more than one immunotherapy drug on the market. And the important question that you asked is, where is the role of immunotherapy, and do we test for susceptibility to immunotherapy? So yes, we do test for susceptibility to immunotherapy, but it's not a genetic mutation. It is a marker on the biopsy that we check that tells us what is the chance or how likely is the patient going to respond to immunotherapy. And the thing is, the difficult part about immunotherapy, if it works quite well for a good amount of time. But if it doesn't work, I tell my patient it's like water through your system. So it's a bit of a flip of a coin, but if it works, it's very, very effective. And if we do find that the patient has a high marker for immunotherapy response, what we call as PD-L1 markers, if it's above 50%, then that chance of responding to immunotherapy is quite high. And we might choose to only do that. One is because the treatment is quite well tolerated. The frequency of treatment can be very spread out. And if the patient is responding, they tend to respond for a good amount of time. So yes, we do test for that. But even if the test is negative, there is still sometimes a small chance of response to immunotherapy that we prefer to add it to treatment. Just in the case that the patient is responding to this treatment, then we benefit from the response and for a long-term response. That said, there's a huge caveat here, which is if a patient has a molecular mutation, a genetic subtypes like EGFR, ALK, and ROS, specifically EGFR and ALK, we prefer to treat those first because the chance of response to those agents is quite much higher than chemo or immunotherapy. And that should probably be the first line of therapy for patients that, again, are not a candidate for resection or, to physically remove the cancer. Then the first line of therapy in patients who have that specific mutations, EGFR and ALK, should be those therapies and not immunotherapy. We can consider immunotherapy in the future with or without chemo, but I would say that the first line of therapy in those patients is a targeted mutation. And again, if you don't have a targeted mutation, immunotherapy should be part of the treatment. The question is when, and at what extent and with what. But immunotherapy should be part of the treatment in patients that don't have a mutation. The question is when.
Very interesting to know. I think for our patients, it's very important that they understand the role of immunotherapy and ask their doctors about it if they are candidates for it. And I also think that's very interesting that you said that there would be some patients who would respond much better to immunotherapy and then others who may not respond so well. And again, that may or may not depend on the level of expression for that PD-L1 marker that we test for. So again, that would mean that, a lot of patients still have to inquire about it and some have to try it to know where they stand in terms of the response. So thank you, Dr. Haroon, for that. Are there, talking about, thanks for the markers and everything, but talking about the manifestations of disease, are there certain symptoms of the disease which patients should watch for, or patients who are higher risk, who have certain occupational exposures, as you had mentioned, or who are smokers or are exposed to secondhand smoking? Are there any symptoms or manifestations that they should be looking for, which would tell them that they are maybe developing lung cancer? Or is it what we call a silent killer, that they don't know until it has a spread, or unless we do a CT scan to screen? What are your thoughts about that, Dr. Haroon?
Yeah, unfortunately, lung cancer, unlike a lot of other cancers such as breast, prostate, is found at a stage that is advanced. And it would be great if we can find more patients at an early stage so we can treat and cure the patients, and we're not stuck at a later stage where the treatment paradigm switches and it's about controlling the disease and shrinking it as much as possible and adding good quality of life to patients. So most lung cancers today are diagnosed at an advanced stage. And it would be great if we can diagnose patients at an earlier stage. And one thing that we talked about earlier today is the screening low-dose CT scan to diagnose patients at an early stage, because early stage lung cancer in most cases is asymptomatic. Again, what are symptoms of advanced stage lung cancer? It could be advanced in the lung, and it can cause more cough, more shortness of breath, and it can definitely cause, blood in the sputum and the cough. And that is typically what we see in some types of lung cancer, such as squamous lung cancer. So that's one common symptom that we see. So respiratory symptoms, breathing symptoms. But in addition to that, there could be chest pain. There could be spread to the bone, so patients can have specific, pain at the site of its spread. If it's in the bone, one of the common sites of spread, and then it can have so many other symptoms that it's very hard to pinpoint. I just want to say, if you're a heavy smoker, or you've been exposed to smoking, discuss that with your doctor, especially if you have symptoms, because the symptoms are not very specific. We can talk about what are the potential symptoms that one will have from lung cancer, and the list goes on and on. So I would say just ask your doctor. If you're a smoker, ask for the screening CT scan, because unfortunately, lung cancer is not something that you can examine and feel and predict early on. It will depend on where it's spread to, and it can cause neurological symptoms. It can cause weight loss. It could be shortness of breath, requiring oxygen, coughing up blood, chest pain. Again, I say that, but the list goes on. So it's hard to say, but all I can say is that, unfortunately, in a lot of cases, lung cancer is diagnosed at a later stage.
Yeah, that's very unfortunate. So I think it's important for our patients to know that it's not only the symptoms that usually are known to point towards lung cancer, such as cough or having shortness of breath or pain or weight loss. It could still be there. It could still be very widespread without having these symptoms. And as Dr. Haroon has mentioned, sometimes it also depends on the location of the tumor, where it is in the lung. If it is in the central location, it may cause symptoms, whereas in the peripheral region, it may be spreading and even going to other organs without the patient knowing that they actually have the disease. So it's very important to still do the screening and talk to your doctor about potential screening options. Yes, sorry, Dr. Haroon, do you want to add something?
No, exactly. Thank you for the clarification. Yes.
So switching gears to the treatment, I know we talked about treatment a little bit when we were talking about the mutations and also the immunotherapy and how important it is in terms of the treatment of the lung cancer today. Dr. Haroon, when do you refer your patients, or when do you recommend surgical resection or radiation or versus conventional chemotherapy? How do you decide which patients are candidates for which specific treatment option?
So this is a very important question, and I would urge patients who are found to have lung cancer in the early stages to make sure that they consult not a general surgeon, but specifically a thoracic surgeon that has good and long-term experience with resecting lung cancer in patients with lung cancer. So it's very important to be at a center with specialized surgeons that can resect lung cancer. But the question you're asking me is about staging. So we stage lung cancer depending on the size of the tumor and the extent of spread. So if a patient has a very small tumor, we call it stage 1. I'm just, giving you very, very general guidelines here.
Right. Yeah.
And if the tumor is a little bit bigger, or there's lymph nodes, so basically the drainage of the cancer includes cancer, so the lymph nodes in the lung are positive, then that makes it a higher stage, potentially 2 or 3. And if it's spread to the other lung or in outside organs, then that makes it a stage 4. For patients who have stage 1 or stage 2 disease, those patients should be considered for resection. So we want to take out the involved part of the lung, and that is one potential, treatment option to try to, get rid of that cancer. But that might not be the only option for patients. But if the patients are operable, if the patients will tolerate the surgery, if they have good lung function, so if they're not too elderly, if they don't have very advanced COPD, then surgery would be the recommended treatment modality for patients with early stage 1, stage 2, and some stage 3 disease. It is very important to note that even if the patient is not an operable candidate, most centers, including GW today, has advanced therapies that are non-surgical to target patients with early stage lung cancer, and that can be therapies such as targeted radiation, what we call SBRT, where high dose radiation can be given to the area of the cancer. Or alternatively, there's other methods of treatment for patients who have early stage lung cancers that are not surgical candidates, which include IR, interventional radiology, where they can go in with a catheter and burn or freeze or ablate the area around the cancer. So please, if a patient is found to have early stage lung cancer, we need to try to eliminate the cancer, ideally by surgery, by resection. And if that is not an option, because the patients are not operable, because they're dependent on oxygen, they're very elderly, then there's other options that can be considered. After resection or after those procedures, that might not be enough. The patients can still have a high chance of this cancer coming back. And the patient and the doctor need to sit down and think, what can we do now to prevent or decrease the chance of this cancer coming back? After surgery, do we consider chemo or not? Do we consider maybe radiation, maybe some other targeted therapies? Those are all on the table and should be considered, because we do know that unfortunately lung cancer, even at early stage, when you get surgery, there is still a good chance of the cancer coming back. And everything needs to be considered depending on the age, the subtype of cancer, and the condition of the patient should all be considered. So just to sum it up again, for patients that are stage 1 and stage 2, surgery should definitely be on the table. For patients that are stage 3, surgery should be considered, but if not, radiation plus chemotherapy should be considered. And this is how I generally sum up the treatment of earlier stage lung cancer to patients. So basically stage 1, stage 2, stage 3, which include lung cancer that has not spread to the other lung or spread outside the lung.
This is very comprehensive, Dr. Haroon. So basically your recommendation is, and I think it's important that our patients hear it out, is that seeing a thoracic surgeon earlier in the course for disease which is not metastatic or stage 4, and also involving radiation treatment options from the beginning is important. And I think that is where medicine is approaching now. So it's all a multimodality approach where I think medical oncology works very closely with surgery and radiation oncology to take care of these very challenging patients who may require multimodality treatment. So and that's how you do it with your lung cancer patients too, right?
Yeah, here I agree. Here at George Washington, what we do is with new cases of lung cancer, we have a tumor board. So it's basically several oncologists, our main surgeon, and our radiation oncologist sit down. We typically do that most Mondays afternoon. We discuss the new patients that we see, and we decide what is the best treatment modality for this patient that's going to be best tolerated and have the highest chance of cure. And we usually present those options to the patient so the patient can opt for the best treatment out there.
Good to know. And then, Dr. Haroon, so once it is outside of the local spread, so once it's a stage 4 or metastatic, which means that it has spread to the other organs, at that point, it is mostly the systemic therapy and mostly it's dealt by the medical oncologist, or is there some role of radiation in terms of palliative approach at that point also?
So if a patient has stage 4 lung cancer, cancer that is spread outside the lung, it's basically how we define it. We do know that surgery and radiation is unlikely to achieve cure. And the best modality moving forward is opting for a treatment that can control the cancer as much as possible and shrink it. That said, you noted something very important, that if the cancer is present at a location that is causing significant symptoms, we do often consider radiation, so palliative radiation. And we have a lot of patients that their initial presentation can be a site of spread like the spine or the brain or the chest, and the patient could be coming with pain. And we do offer those patients some form of radiation to control the disease locally, and then something either by mouth or by the IV to control the spread of the disease in all the body. So we do local therapy to prevent local symptoms, and then general therapy in the body to control the disease, to shrink it as much as possible, and to prolong the life of the patient as much as possible. We have opted also to offer radiation after treatment too. So if a patient opts to start treatment first and would like to consider radiation in the future, that's something that we consider too. But generally speaking, patients who have stage 4 disease, it is a different modality of treatment. We're not thinking very aggressive up front just because we know the chance of cure is low, and we would like to reserve all the options to be given at later stage to prolong the life of the patient as much as possible.
Thank you for that, Dr. Haroon. So as Dr. Haroon mentioned, that there is a still role of radiation in stage 4 disease for palliative control of the disease to help with, certain symptoms. And also there are other things such as, a lot of times these patients are developing fluid in the lung. So there is a role for drainage for that and stuff. So there are a lot of options out there for our patients in the stage 4 setting also. As Dr. Haroon has explained very well. So Dr. Haroon, I'm going to thank you for all this. I'm just going to quickly ask you about the recurrence. So in patients that you had mentioned, you would treat with chemo or radiation with the curative intent in early disease, or patients who go for surgery for resection of stage 1 or stage 2 disease. What are the chances of recurrence after complete resection or after they have completed their radiation treatment? How often do you recommend these patients should be monitored, and what are the factors that influence the development of recurrence, and how should we prevent them?
Yeah, so for patients with stage disease that are treated with either surgery plus or minus chemotherapy or radiation plus chemotherapy, those patients should be monitored very closely by their surgeon or their oncologist. And typically we get scans, either PET scans or CT scans with contrast every 6 months, up to 5 years. We can space them out a little bit more than that if we choose to with the patients. But it's very important to monitor closely, because even patients with stage 1 disease can have a 20-30% chance of the cancer coming back. For stage 2 disease, that is higher. And for stage 3 disease, that chance is much, much higher. That said, for patients with stage 3 disease that today are treated with chemo and radiation, we know the chance of the cancer coming back, what we define as recurrence, is quite high, that we offer them 1 year of adjuvant immunotherapy to decrease the chance of recurrence. So if someone has stage 3 disease treated with chemoradiation, we historically used to say patients have a 50, 60, maybe even above that chance of the cancer coming back. So we offer them 1 year of immunotherapy to decrease that risk significantly and to increase the chance of cure. So we have modalities and close follow-up and treatment after resection that can mitigate or decrease the chance of recurrence, or follow closely so the patients can be treated with the earliest sign of recurrence. I have to add some other small caveat in patients who have an EGFR mutation. Those can be followed very closely or can be given some form of an EGFR inhibitor, so the pill, even if there's no cancer, to prevent it from coming back. But generally speaking, what we do is for patients after resection, we consider a chemo and then we follow very closely. If the cancer were to come back, then again, everything is back on the table. We consider chemo, we can consider radiation, we consider targeted therapies, we consider immunotherapy. We even consider sometimes surgery again if the recurrence is local, and we've seen that in a lot of patients. So with recurrence, that doesn't mean it's the end of the end of the line here. We still have all the options on the table, and please. I want patients to go ahead and get their screening, to get their monitoring, to be followed closely, because if the cancer were to come back, we know that that's possible. We still have a lot of options for treatment. I cannot define the options because at this point in time today, they're endless. And it just takes the patient to spend a little bit of time watching TV today to hear the list of all the drugs that are being approved for lung cancer, and being told to ask your doctors about it. And again, that treatment will have to match the cancer specifically, and the oncologist and the patients will sit together, talk about all the possible treatments, and use a little bit more of a personalized approach to figure out what treatment works best for which patient and which type of lung cancer. And I'm not going to talk too much about the chemotherapy options, but that's always going to be an option. So but we would like to defer the option of chemo until it's completely necessary. So if we can give targeted agents, immunotherapy, surgery, radiation as a primary option, we opt for that. But again, chemo is an option too.
Good to know. As Dr. Haroon said, it is very important for patients who have completed treatment for early stage disease to closely follow up with their medical oncologist, their surgeon, because the cancer can come back. And if it comes back, there are still options available. Recurrence happens, and it's good to sort of think ahead and keep the close follow-up, because the earlier we find out, there are more and more options for those patients. I think I'm going to wind this up. I just have one last question for you, Dr. Haroon. In the era of all these multimodality approaches, surgery, radiation, cytotoxic chemo, molecular targeted agents, given in the setting of curative disease as well as the palliative treatments, the side effects are of particular concern to a lot of our patients. And some of these treatments can have potentially negative effects on the quality of life during the treatment and sometimes after the treatment. In terms of the toxicities, where is medical science today? What are we offering our patients to help with those toxicities and improve their quality of life?
Yeah, I think that most patients are sick from the cancer and not from the medicines we treat them. And I really need to stress that point. If the cancer goes on without treatment, then the patients will have symptoms. And that's why we need to treat, and we need to think about the best options for treatment. But as you mentioned, Dr. Thibault, there's a lot of new medicines on the market, and each medicine has a different side effect profile. So I will have to urge patients to not worry about the specific symptoms of what they call conventional chemotherapy, which is nausea, vomiting, losing weight, because that does happen with some of the chemotherapy options today, but it doesn't happen with the other newer therapies that we have on the market, because those therapies have different side effect profile. I have to say they're generally more tolerated, but you need to be followed by a specialized oncologist, by your oncologist that are comfortable using these medicines, because the side effects are less common, but they're very specific side effects that have to be thought of beforehand. I would give you an example of the EGFR blocking agents, the inhibitors. Again, the side effects can include rash, sensitivity to the sun, diarrhea, cough, but generally well tolerated. Again, if you move to immunotherapy, the majority of patients don't have any side effects to immunotherapy, but a few patients do get some side effects. So it's very important to monitor those symptoms, because if side effects do happen, we know what to do. We know that we can stop the medicine, restart, lower the dose, or for immunotherapy, we can take a break. And again, having side effects does not mean that the drug is not working. So please think about the medicines. Ask your doctor about what side effects to expect and what to do once you have the side effects, because side effects can be managed today. We're in 2020. This is not 20, 30 years ago, where we did not have options for treatment and treatment was super toxic. We're in a better place today. And patients that get lung cancer today have a lower chance of dying than patients that, got lung cancer, 10, 20, 30 years ago. I tell patients that if I tell you what the average lifespan of a patient with lung cancer is today, that only reflects, the data we have from 10 years ago. It doesn't reflect the data that we will get today. And the chance of living with lung cancer today can exceed, 1, 2, 3 years. And we've seen some patients with immunotherapy, even stage 4, living beyond 5 years. So the question becomes, how do you live longer, but live and tolerate the medicines with minimal toxicities? And that's why I urge the patients to ask the doctors about what is the best treatment that would be tolerated by me, and what should I watch out for.
This is excellent. I think this is very important.
About toxicity.
Thank you. This is, I think, very important what you just said, that, the data that we have is from 10 years ago. So the data is only improving, and the mortality rates are only going down, and patients are tolerating it even better. So that is definitely very encouraging for our patients in today's new treatment options. Pleasure having you, Dr. Haroon, on our show tonight. Thank you for educating our patients about the lung cancer, and I hope it was educational to our patients. We really appreciate your help here tonight.
Dr. Thibault, thank you for the invitation. I always love chatting with you. It was great working with you back in the days. I'm sure patients are lucky to have you, and You're very personable, and I know that you're a great advocate for patients. So looking forward to chatting with you again. And if you have any questions or your patients have any questions, it would be my pleasure to, again, sit down with you, discuss those cases in the future if they come up.
Thank you so much, Dr. Haroon, again.
Thank you.
Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.